So thank you very much for coming. I now declare open this public hearing being held in Canberra of the House Standing Committee on Health, Aged Care and Sport for the inquiry into health impacts of alcohol and other drugs in Australia. In accordance with the committee's resolution of the 4th of August 2022, this hearing will be broadcast on the Parliament's website, and the proof and official transcripts of the proceedings will be published on the Parliament's website. I now welcome witnesses from the Glen Group to give evidence today. For the Hansard record, before giving evidence, could you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to give a short opening statement of no more than 5 minutes before we proceed to discussion. Thank you.
No worries, thank you. And I'll kick off and then I'm going to hand over to Alex before we can take questions. So, my name is Joe Coit. Myself and my colleague Alex Lee from the Glen Group, which is a 69-bed Aboriginal community-controlled drug and alcohol rehabilitation centre located on Darkinjung land on the beautiful New South Wales Central Coast. The 69 beds are spread over 40 beds at the Glen for men, 20 beds at the Glen for women, and 9 about to open in the Glen for Women transition program. My current role, Executive Director of the Glen Group. I've been involved at the Glen for over 25 years in many different roles, and I've also had the pleasure of visiting many communities across New South Wales and Australia, and even globally through my work as Acting CEO of ADAN, the Aboriginal Drug and Alcohol Resi Rehab Network, and working as an accredited reviewer across both Australia and New Zealand, especially of Aboriginal medical services and rehabs. And I've travelled globally last year as part of my Churchill Fellowship, which I supplied the report to you guys. I'm humbled to have been welcomed to many drug and alcohol treatment services across urban, rural New South Wales and across all those jurisdictions I travelled overseas. In regards to drug use, we acknowledge that humans have consumed drugs including alcohol for thousands of years, perhaps more, and this is not likely to change anytime soon. Some drug consumers, probably most, don't suffer significant immediate adverse consequences or create significant societal problems from their usage, although all drug use does cause some longer-term harm. In regard to problematic drug use, the use itself is often only the symptom of the real problem, and the people who are more likely to be involved in problematic drug use are the people who don't score well in the basic social determinants of health. Sadly, the most vulnerable people in our community are overrepresented in all problematic drug-related statistics. I note the terms of reference include the inquiry to examine our existing alcohol and other drug policies, and after seeing many examples of decriminalisation and legalisation through my travels, I would suggest that any notion that there is a simple fix through legal changes needs to be dismissed. What appears to be most important is that we carefully consider the context in which change is made. Regard needs to be had to many issues, including but not limited to the economy, the social characteristics, the user characteristics, drug types and availability. Regulation and the like is perhaps the only thing that I saw universally that definitely needs to happen and be correct. In saying this, I don't think many people these days would argue that anybody should be discriminated against or impacted negatively long-term because of their own personal drug use. There are many possible examples in Australia for opportunities to increase diversion programs and options for people found in possession of drugs that is for their personal use. The criteria for these programs is important, and if they are to achieve the outcomes on the ground of treating drug users as a health issue and not a criminal justice issue, the criteria needs to have sensible thresholds and not discriminate between different drug types. We need to review what we are doing in the drug and alcohol treatment space. We need to embed what is working in a sustainable way and have an honest conversation about what is not working. We either need to support things to get better, or we need to change, adjust, pivot where we are putting our limited resources to achieve better outcomes on the ground. The services that are doing well in regard to achieving these outcomes on the ground, they need and deserve to have a more sustainable funding model negotiated to let them do this most important work. We need to also review the outcomes on the ground that are being achieved by the departments across Australia including New South Wales Health Centre of Drug and Alcohol, Federal Department of Health, the National Indigenous Australians Agency, and other state and territory jurisdictions who fund drug and alcohol treatment programs. We need to make sure that they are this review should focus on evaluating both the services they are funded, like discussed earlier, by meeting people, seeing them in action, the real on-the-ground stuff, not just a desktop audit, and then consider whether the current practices in each of these departments regarding probity, designing tender specifications, etc., are leading to the resource allocations that will achieve the best outcomes on the ground. There is no amount of money that will fix this problem if the money is not going to the right people and places. Over my career, I've progressed from thinking that the work we do at the Glen Group is very good to knowing that it's absolutely best practice. And a leader in the field as it uses the ADARM model of care, which is the Aboriginal Drug and Alcohol Rehab model of care. And I think it's important for treatment providers to be fit for purpose for their local communities in which they operate. And I believe that there is a need for a varied treatment sector, as different clients do have different needs, and a varied treatment sector needs to include prevention, harm minimisation, and abstinence-based programs, or recovery-based programs. I also believe there should be a role for experienced quality providers to be part of supporting getting the outcomes on the ground across the sector as a whole and not just in their own service. This could be the case in a service that may be struggling to be the best version of itself, or if there is a new service being established in a new community. Currently, if government identify a need for a new service like a drug and alcohol rehabilitation centre in Dubbo, for example, the process of acquiring suitable land, designing a functional facility and then running a tender process is often done by people who have no real knowledge or expertise of what is required to achieve the best outcomes on the ground. Sadly, probity is often used as an excuse or a reason to exclude well-intentioned people who know what is required and simply want to help to make sure the money put into this project achieves the actual outcomes on the ground as expected. So as I transition to Alex Lee, I'd like to say that I'm glad to see that we're looking to assess whether current services across drug, alcohol and other drug sector are delivering quality for all Australians in regards to outcomes on the ground. And after spending my whole working life in this sector, and after meeting so many people in the Glen program and talking to family and friends of these people, the only thing that matters to me is the outcomes on the ground. It's that simple. All topics we discuss should be aimed at improving outcomes on the ground for people who are either suffering from their own substance use or being impacted by the substance use of others.
Thanks, Joe. My name's Alex Lee. I'm a chartered accountant and was a former auditor and tender writer at KPMG, who worked with listed companies between Sydney and London for the first 7 years of my career. But through KPMG, I was seconded to the Glen 10 years ago in 2014 to initially help the Glen with its financial sustainability. But what I fell in love with was a sense of belonging and purpose around the fire, and started working permanently the year after. I've had the privilege of being the CEO of the Glen Group for the last 5 years. I guess I've had two major highlights in my career at the Glen. I guess the first highlight was working, during COVID. Living on site for 7 weeks straight during the first lockdown will always be one of my greatest highlights of my career, but of my life, of spending time on the ground with the clients. Another highlight was being part of establishing the Glen for Women, New South Wales' first Aboriginal community-controlled resi rehab for women, and now helping other communities establish their rehab centres too. I'm also the co-chair of New South Wales Peak Body's Data and Research Advisory Group of NADA. And my motivation for chairing that group is that I believe that good quality data is a starting point to improve services, to improve outcomes on the ground. I'm proud to have hosted this year's New South Wales Data Forum, which brought together over 100 people from government and services to talk data, share challenges, ideas and solutions. And from where I sit, there's three opportunities around data. I think there's an opportunity for better quality data on outcomes. At the Glen Group, we are attempting to begin a data linkages project to use large linked data sets to better understand the long-term outcomes and benefits, including health, employment, education, and social outcomes. We are working together with 7 Aboriginal community-controlled resi rehabs around Australia as part of this project, and hopefully we can secure financial resources to see this project become a reality. I believe that there's an opportunity for better data transparency. We as the Glen are accountable to the stakeholders, but more importantly the community and clients that we serve. And so the Glen has started a journey of making our data more transparent through a dashboard which is online, which provides timely data about our occupancy and client outcomes. This dashboard is just the start, and we hope to expand and include more KPIs, which is open to community to see. And last, there's an opportunity to improve on data gaps. Myself, from a culturally and linguistically diverse background, we see a lot of data gaps in our sector, meaning resources aren't directed to where they're needed the most, and we need to consider new ways of collecting data. I've learned from my time at the Glen so far is that community-led and culturally appropriate programs are key to improving outcomes on the ground. Thank you.
Good. Well, we might start with questions. Julian, would you?
I've put a couple of questions to Alex, a couple of questions to Joe. What are the data gaps that you're seeing, and what is the data that you're actually reporting on at the moment?
Yeah, so the data gaps we're seeing is on many levels. I think it's at the outcomes level. The project that we want to embark on around data outcomes is where clients leave our program afterwards, what is their situation happening? So, the founding purpose of the Glen was to reduce Indigenous incarceration. So we're hoping to see data on, are they back into the criminal justice system? Are they employed? What are their health outcomes? Are there reduction in hospitalisation? So outcomes is a big missing area.
And you would just collect that data by staying in touch with the person, or are you looking for data from the state and Commonwealth agencies to the extent that they're there?
So our proposal is to use existing government data sets through PLIDA, which is part of the ABS, which does link big data sets. There's over the next 12 to 18 months, there is some state data which is moving into that as well, into that system. So our proposal is using our client data and linking it with existing government data sets to see situations before rehab and then after treatment as well. So a potential longitudinal study.
At the moment, do you keep any data through your own maintenance of contacts with people as to what's happened to them?
Yes, at the moment we keep a lot of data while they're in program. Yep. So we collect minimum data sets, outcome measures such as what they call the severity of dependence score, quality of life scales, K10, which are collected through surveys regularly during their stay. So we have a lot of good quality data during program.
And is that data that you decide to collect, or is that data that's mandated by government agencies that give you funding?
That's mandated, yep. Yeah, mandated by funding and national minimum data set requirements.
And it's helpful data.
Yeah.
And you can actually use it for clinical interventions and stuff. But what we're saying is more meaningful data is actually where are people in 6 months, 12 months, 18 months' time. Yeah.
I suppose I just want to push back. Why can't you stay in touch with the people and collect that data? Isn't that easier for you to do for your own services rather than try to aggregate these big data sets that are coming through from agencies?
I suppose there's a couple of things on that. I mean, we could, but it'd be very expensive. So obviously someone would have to do it. It takes time, but also I actually think it's quite burdensome on the people. So I think what Alex is suggesting around data linkages. So to do those surveys takes 10, 15 minutes. It can depend. But when people are a success, they don't really want us ringing them, and constantly checking in, especially if they feel we're only doing it for data purposes. So we do outreach stuff to try and check in with people to make sure they're well. But I think what we're suggesting here is to get a really good idea of, and it's not just about the Glen, this is for government to get an idea of the impact of the money they're spending. The big money they're spending on treatment is to fund a small data link project, if that makes sense. And you use the existing data sets, cost very little.
I think it would probably help us formulate some recommendations if you could perhaps think about some specific examples of what's missing and perhaps put something down for us by way of submission, or even just a short note, which might help us. Yeah. Mr. Cook, I just ask you a couple of questions. Other than community controlled, culturally appropriate services. What else do you think makes dealing with Aboriginal drug and alcohol rehabilitation different? And what's the secret sauce, as it were, if there is a secret sauce, and is it scalable?
Is it scalable is a really interesting question, and because of the success of the Glen, we've often had, opportunities, I suppose, to become start franchising. And the word of our board is no, it's not what we do. We operate the Glen well, and we're very proud of what we do because we operate it on our country and we're all members of the community. Does that make sense? Yeah. So what we say is we're not interested in operating a rehab in other regions, but we're more than interested if the local community in that region say, hey, can you just come and help us? We go in and we will help them and just talk through, I suppose, systems, processes and things we do, and we encourage them to take what they think will work in their community and leave the rest, or tailor the rest, if that makes sense. So really the secret sauce, I think, is, you talked about it has to be cultural programs, but it's the right community members driving the rehab. Big part of the solution of this stuff is just better connections, and as a society, I think, I know we were at the Q&A the other week where Monique, there was a discussion on that, connections, and how that's obviously, being an active member in community is a big part of this solution. Simple stuff, like good thing you don't need to be a doctor or a professor to actually have to understand this, because a simple guy like me can work at a place for many years and help make an impact.
Last question from me, Mr. Court. We've had lots of people tell us about issues around stigma of going to get treatment in relation to addiction, and that there's a real difficulty around stigma. I've had in other contexts people in the Indigenous world say to me, community controlled is a really good principle, but sometimes when the community is quite small, there's a real stigma about going because I've got, this uncle or auntie or this relative, and it's really bad for me to go, and I would rather a more anonymised person where I didn't feel that I had to fess up to the fact that I'm struggling in this space. Do you want to say anything about that?
I think stigma is an issue. I think even in the healthcare system, I think there's a lot of stigma against people who have problematic use of drugs and alcohol. In regards to your second part of the question there, I think it's important we have a variety of treatment options. I think that's the solution, right? So I think there's a real place for the right Aboriginal community-controlled organisations, but I think it's also important that anyone, including Aboriginal community members, have choice of service, because, I've heard that a million times as well over my sort of career, that some people would prefer not to attend an AMS, where others, it's the absolute best place for them to be. So, it's a hard one, but definitely, I think stigma, definitely an issue. And I suppose at the Glen, one of the things I'm most proud of is over the last 30 years, we turned 30 this year, is we've actively tried to reduce the stigma around drug and alcohol and mental health issues, and I think we've done a fantastic job by being really open and transparent with our community. You wear the Glen shirt around the Central Coast and you don't feel less than. You often might get offered a free coffee even, so but you're not getting a shirt, Mike. But I think, for us, we've sort of really been on the front foot trying to get rid of some of that stigma and make people proud of. People with problematic drug and alcohol use are just people, like the rest of us, and it impacts everyone. As I said at the start, I think, obviously the more vulnerable people are definitely overrepresented in the statistics, but this stuff's, we're all human,
I like what you do, I've seen it, so keep doing what you do.
Thank you.
Thank you both for what you do. It sounds wonderful. Mr. Lee, I think you're the only person in the world who enjoyed a 7-week COVID lockdown.
We had access to the gym, we had food.
He was locked down on a very nice facility.
I'm glad to hear it. Yeah. Can I ask you about how you fund the centres? What the basis of that, the funding model is?
Yeah, so the Glen has a mix of federal and state funding. It comes from Commonwealth Department of Health, National Indigenous Australians Agency, different streams of funding through the primary health networks as well. And then we get New South Wales Ministry funding and also local health district. We also get some, philanthropic funding, and then we generate some of our own income. division.
I'm happy to keep sitting here.
Yep.
It's an amendment. I think I have to go.
Yeah.
Are you on the stage here? Because you can continue as a
Yeah,
subcommittee.
yes, we'll continue as a subcommittee. I'll get into trouble for it, but it doesn't really matter.
It's okay. Sorry. My misdivisions against you.
Thanks, Lenny.
Do you want to keep answering Dr.
Yeah,
Wright's
well, I
question?
guess the rest of the Glen's funding comes from its own self-generated income as well. We have board and lodging from clients, but then we have our consulting arm. So the Glen, from 7 years ago, we have to. Financial diversification is an important thing for a charity to be sustainable, and so we do consulting work and projects for other services which have aligned objectives, and we generate our own income that way as well.
And I think it's important. So the values have to align, as Alex said, for us to do work in the consulting space, but also in our funding sphere is quite big at the moment, but we're really big on we need to have genuine partnerships. And so we're getting away from, to be honest, working with, I suppose, government departments that are telling us what needs to be done, being overly prescriptive in it. We're weighing up if it's X amount of dollars, yet the reporting burdens are just too big. Like we're not interested in taking any money that's on offer. We're starting to really apply criteria and make sure it's money that's going to help us achieve outcomes on the ground. That's all we're about now, and we're really big on it. And sometimes that means we do have to politely push back and even walk away from money, because I just think it's, unless it's going to help people on the ground. And one of the things we've always said at the Glen on the board, it's like, if it's going to, does it affect clients today or potential clients that will need us tomorrow? And if it doesn't, then why are we getting involved? Like that's our purpose, so we're pretty true to that.
I've got a number of questions, but first of all, I just want to go back to the data collection. You must find it very difficult to get data about outcomes from things like criminal justice system, health. Is that...
That's the journey, right?
Yeah. So at the moment, we've got a proposal which where we hopefully is successful, where we want to start accessing some of that data. There have been services which have done this process before. This will be our first time, but there is a lot of barriers of consent and trying to get access to that data.
Issues, I guess, as well.
That's right.
So how do you address that? Have you worked with the criminal justice system to try and improve access to data, or the health system? I'm just curious how you're going to do this.
No, so we're working with, there's a few experts we're working with through UTS, UNSW and Wollongong who have done this before, but with kind of more limited data sets. Well, this will be a first time trying to access criminal justice data.
I presume you've got a funding need for that?
There is a funding need, and we have a proposal right now through the Medical Research Future Fund.
Oh, great.
But that's still pending.
Still pending, is it? Yeah. So when do you hope to hear about it?
It was submitted yesterday. So
Early days.
very raw and fresh.
So tomorrow would be that we're hoping to hear, if that's all right.
Yeah, all right. Well, that's good to know.
And the scale of this project is national as well, with 7 services from 5 different states participating.
And I think if this works, the big issue is we need it to be, these one-off research projects get done in our space, and they're good, but it's like, we need to be looking to embed evaluation and better data outcomes into the system. I think that's a frustration, and I suppose, from a department perspective, I'd love to, really understand who's funding what and what outcomes on the ground are we achieving as a society, because that's what we're doing, that's what we're trying to do, right? Like, for instance, in New South Wales recently, there was a $500 million investment after the ICE inquiry. Now, we've got to make sure we monitor that to actually see what outcomes were achieved on the ground. It's not about who you funded, so you can tick your box and say, we gave that person that money, that person that. No, I don't think anyone cares, right? As long as the outcomes on the ground is worth $500 million improvement to the
Yeah,
state of
no,
New South
well-
Wales.
As you're probably aware, we've got Thurrow Aboriginal Health Service in my electorate, Macarthur, and I've worked with them for over 35 years now, and there's a long history of short-term research projects and, no clear idea about outcomes, and we need to do away with that, so I totally agree with you. And it would be nice to see what we can recommend that may help you when we come to the end of this inquiry. But can I ask, are you seeing any trends in your clientele? Like, is there a trend away from alcohol as a problem to more other drugs? And if so, what are they? Or is alcohol still the major issue?
Well, for us,
Yes.
And it's not the same in every service, and comes back to the moment, like rural services, Indigenous, tends to. So for us, when people enter the program, we ask them what's the primary drug of concern. It's amphetamines. So for us, ahead of alcohol, and that switched a fair few years ago now. But I know that's not the same for some big city services, if that makes sense. But I think the other trend is, or one of our big challenges too, is that we've taken the most vulnerable sort of members of the community. We're doing well with them, trying to get people to exit in a safe way as soon as possible. That's probably one of the trends that's worrying me, because it's creating a bottleneck. People are doing really well in treatment, and it's housing. And employment's not that bad at the moment, but even if you're employed, you still can't get housing if you're applying for housing. So I think that's one of the trends I'd like to sort of flag and say people are tending to stay a little bit longer, and with all due respect, they've probably finished their treatment, but they're doing everything they can, and we've just got to work really hard with them to try and get that. It's hard out there. Look, I feel very blessed, that's for sure. Any trends that you're...
No, I think it's the same trends. Yeah, I think 10 years ago, from our data, alcohol was in the lead as a primary drug of concern, but now it's close to 65% ice and amphetamines.
And keep in mind a lot of polydrug use there. So people using, we ask them for their one drug of concern. What's the major one? So they're probably using, or they're often using numerous drugs. But that's what they're telling us is the one that's worrying them.
Can I ask you, with your other connections to other Aboriginal controlled services, are you seeing the growth in amphetamines and the like as opposed to alcohol now across the country, or is it specific to your community?
So different in different regions, right? And I hate trying to talk on behalf of another region. I always get nervous about doing that, so that's me. I want to make sure I say that front up, but we've been doing a fair bit of work in the NT. In the Northern Territory, and it's alcohol. They have services out there that are actually mainly funded by the NT government, and they're funded for alcohol only. So that tells you it's starting to sneak in, but things like Northern Territory is starting to see an increase in the meth. Regional towns in New South Wales, I won't name the town, but we were recently there for the New South Wales Drug Summit, one of the forums, so you can guess it. They're seeing an increase from what I heard on the ground, so as I said, not in the summit, but I went and spent 2 days prior with people in the community and on the ground. They're talking about a lot of the ice is actually getting replaced by cocaine, and while no one wants to sort of encourage any of that behaviour, it's probably a harm min strategy, to be fair, if you've got people switching from amphetamines to cocaine. So every region is so different, and I think that's one of the things we've got to consider when we look at policy, and then we've got to keep it fluid so it can change and pivot as things that are always going to change in the drug usage space. Okay.
Okay. I've got to go. Sorry.
No worries.
Try and get back. Yeah.
Thank you very much, Mark.
You no longer have a quorum.
Right. So you're going to suspend?
You on the
Yes.
I think the chair did.
Well, the broadcast is off now.